Good afternoon, friends. Today, and welcome to ePathshala. In the subject of social medicine and community health, under the healthcare delivery system, we are going to continue to talking about community health center organization and functions today. The development team, as usual, we must thank Professor C.P. Mishra under his guidance and his team from Aligarh Muslim University. And like I've always mentioned, we cannot emphasize enough the learning objectives. And in this case, at the end of the lecture, we should be able to know the introduction and the background, the service delivery at the community health center, minimum requirements at community health center, and the Indian Public Health Standard objectives for community health center, and last of all, what are the functions of this community health center. Now, this is a very nice picture of a community health center, and as you can see, it's not exactly a small center because it is definitely a 30-bedded hospital, and it has to be situated in a place which is central to the rural area to which it governs. Now, to introduce this particular subject, healthcare delivery in India has been envisaged at three levels, namely the primary, secondary and the tertiary levels. The secondary level of healthcare essentially includes community health centers or the CHCs, the sub-district and the district hospitals. The CHCs were designed to provide referral healthcare for cases from the primary health center level and for cases in need of specialist care approaching the center directly. So either you can have referral or you can have patients coming to the center directly. 4 PHCs are included under each CHC, thus catering to approximately a population of anything between 80,000 population in the tribal and the hilly desert areas, that is the special areas, or up to 1,20,000 population for the plain areas. Now, under the National Rural Health Mission, this was created, and it has given us the impetus that CHC has a 30-bedded hospital providing specialist care in medicine, OBG, surgery, pediatrics, dental, and of course, let us not forget the third wing of the medical treatment, that is Ayush. This means the indigenous medicine system in India. The launch of the National Rural Health Mission, NRHM, gives us the opportunity to have a fresh look at the functioning. NRM envisaged bringing up the CHC services to the level of Indian Public Health Standards. And although there are already existing standards as prescribed by the Bureau of Indian Standards for a 30-bedded hospital, these are not present, not achievable, as they are very resource intensive. Now, under the National Rural Health Mission, the accredited social health activist, that is the ASHA, is being envisaged in every village to promote health activities. With ASHA in place, there is bound to be a groundswell of demand for health services, and the system needs to be geared to face the challenge. In order to ensure quality of services, the Indian Public Health Standards, the IPHS, are being set up for CHCs so as to provide a yardstick to measure the services being provided. Now, objectives of the Indian Public Health Standards. What we need is to keep up a standard so that which is equivalent and which is comparable to the rest of the country. We need to provide actually optimal expert care to the community to achieve and maintain an acceptable standard of quality of care and to ensure that services at the CHC are commensurate with universal best practices and are responsive and sensitive to the client needs and expectations. So therefore, standards have to be maintained if we want a comparison of some sort. Now, what is the service delivery in CHCs like? So we have the emergency services. This is one thing which is open 24/7. And we have the OPD and the inpatients department services. Inpatient, we have actually 30 beds. And OPD for all the specialists who are sitting there. Then it is connected with the national health programs, and of course it has its own laboratory services including X-ray facilities, which is very important and which is not available in the primary health center. Now, every CHC has to provide the following mentioned services which have been indicated as essential and desirable. All states and union territories must ensure the availability of all essential services and aspire to achieve desirable services which are the ideal that should be available. Now, care of the routine and emergency cases in surgery. Now, since we have the 24/7 emergency OPD, this will include dressings for cut injuries, etc., or minor accidents, incision, drainage, surgery for hernia, hydrocele, appendicitis, hemorrhoids, fistula, and stitching of injuries, handling of emergencies like intestinal obstruction, hemorrhage, etc., other management including nasal packing, tracheostomy, foreign body removal, fracture reduction, and putting splints and plaster cast. Now you see, because all these are only possible because there is an OT 24/7, there is an X-ray machine there, and there is a surgeon there, and there is an anesthetist there. So therefore, we put together, this forms a very good service which is essential for the rural areas. And besides, we are conducting daily OPDs. Now, what is essential in care of routine and emergency cases in medicine? Special mention is being made of the handling of emergencies like dengue hemorrhagic fever, cerebral malaria, and others like dog and snake bite cases, poisonings, congestive heart failure, left ventricular failure, pneumonias, meningoencephalitis, acute respiratory conditions, status epilepticus, burns, shock, acute dehydration. All these will need the active services including oxygen, X-ray, and surgery. So therefore, these services we are able to give them. In case of national health programs, appropriate guidelines are already available which should be followed. Conducting daily OPD. We are conducting daily OPD as far as these are concerned also. Now, maternal health is a very important component, and we have, since the gynecologist is there and the lady health visitors are there and the midwives are visiting from the field areas, and the ASHA as well as the other lady workers are also visiting. So therefore, all these people are gathered together in the OPDs for antenatal clinics. So therefore, for every case, a minimum of 4 antenatal checkups including registration and associate services, in which case means you register, you take the blood pressure, do a urine examination, and you generally fill up her card and examine her. Now, with the first visit, it should be preferably within 12 weeks. Preferably as soon as pregnancy is suspected, for registration of pregnancy and first antenatal checkup. Now, we have to take this with a pinch of salt, because since we are in the rural areas, till now, of course, most of them are changing to the newer methods of reporting early, but we still have people who prefer to wait for the second period to be lost. In other words, it is, the 12 weeks holds good, but they never come after the first period is missed. So, first visit is done within the first 12 weeks, the second between the 14 to the 26 weeks, third between 28 and 34, fourth visit between 36 weeks and term. And the 24-hour delivery service, including normal and assisted deliveries, is a provision for availability is present at these centers. Then, preferably when we do the labor, when a labor is conducted in the CHC, they can do it using the partograph. What is a partograph? That is, it is a diagrammatic representation of the progress of labor in terms of a riding chart. So, we start with the labor pains, and if the labor pains increase, the chart goes up, and with that chart we can directly envisage what is her presentation of the labor going to be. All referred cases of complications in pregnancy, labor, postnatal period must be adequately treated. For example, a person comes with toxemia pregnancy, so she must be admitted, her blood pressure must be treated, her edema must be treated, and the baby has to be checked continuously to know that the baby doesn't go into difficulty in breathing. Ensure postnatal care for 0 to 3rd day at the health facility, both for the mother and the newborn, and sending direction to the A&M of the concerned area for ensuring 7th and 42 day postnatal home visits. Minimum 48 hours of stay after delivery and 3 to 7 days stay post delivery for managing complications in case she has bleeding or a retained placenta and difficulty in removing the placenta. So, with the baby was born slightly with difficulty in breathing. So, if it was a difficult labor, we must make the patient stay. Both the patient and the baby must stay for at least 3 to 7 days. Now, proficiency in identification and management of all complications, including PPH, eclampsia, sepsis, etc., during postnatal care. Then essential and emergency obstetric care, including surgical interventions like cesarean sections and other medical interventions. Provisions of Janani Suraksha Yojana and Janani Shishu Suraksha Karyakram as per guidelines. Now, for the newborn and the child health care, it is important to know that essential newborn care and resuscitation by providing newborn corner in the labor room and an operation theatre where the cesarean takes place. Early initiation of breastfeed within 1 hour or 30 minutes of the birth and promotion of exclusive breastfeeding for 6 months must be promoted. And there should be a newborn stabilization unit in case the baby is slightly underweight or has had difficulty in breathing or has a prolonged labor as a result of a prolonged labor. So the baby could be put in the newborn stabilization unit to take care and to see that the baby comes down to normal. Counseling on infant and young children is a part and parcel of the IVCP guidelines. Now, in routine and emergency care of sick children, going on to the under 5s or of the sick children, including facility-based IMN-CI, full immunization of infants and children against vaccine-preventable diseases and vitamin A prophylaxis as per the guidelines of the Government of India, and most important, tracking of vaccination dropouts and left outs, because these definitely, if there are dropouts and left outs, they form pockets of non-immunity areas which are prone to getting the diseases. Now, prevention and management of routine childhood diseases for infections and especially anemia in mothers and children. And we must also see to the fact that the children may not be having worm infestation, as a result of which anemia could be the result. And management of malnutrition cases. Since there is a vicious circle between malnutrition, anemia, and worm infestations and the habits of the families. So this has to be taken as per the JSSK, that is the Janani Shishu Suraksha Karyakram guidelines. Now, family planning. Family planning is a very, very essential part of the life of any family, and it is essential that the full range of family planning services, including IEC, counseling, provision of contraceptives, non-scalpel vasectomy, laparoscopic sterilization services and their follow-up, safe abortion services as per MTP Act, that is within 8 weeks is totally safe, and beyond that they would require other rules and regulations would come in. For example, you need the okay of 2 doctors before any abortion can be done if it is needed or indicated medically. Otherwise, if a woman comes and says that she needs MTP, then this can be done provided the rules are met with. And desirable is the MTP facility approved for 2nd trimester of pregnancy. That, like I said, if it is above 12 weeks, then care has to be taken. Now, what are the other national health programs which are run through the CHCs, which should be important? Now, all national health programs should be delivered through the CHCs. And integration with the existing programs is absolutely vital to provide comprehensive services. So, because you can't have parallel run programs going separately on their own ways, because at the end of the tunnel is the one single family which needs full care. So, whether it is the family planning, whether it is national malaria eradication, leprosy, or tuberculosis, or any of the others, or spraying, it has to go to the family level, wherein all the projects will meet at a point to give unified single program. The requirements for the important national health programs are being annexed as separate guidelines following other assured services under the national health programs. Now, what are the communicable diseases? Let us start counting. First of all, the revised National Tuberculosis Control Program. The CHCs should actually provide diagnostic services through the microscopy centers which are already established in the CHCs and treatment services. Now, for HIV and AIDS control program, the services to be provided at the CHC level are integrated counseling and testing center, blood storage center, sexually transmitted infection clinic, since HIV is very close. And for this, the NACO takes into action and gives the guidelines which are followed by the CHCs through a simple program. Most desirable for HIV, the antiretroviral therapy center, so that in case HIV cases are registered, are diagnosed, they would be getting the medicines right from the CHC itself. Now, the National Vectorborne Disease Control Programs, which includes a vast majority of the national communicable diseases in our country, like malaria, filaria, dengue, Japanese encephalitis, Kala Azar in respective endemic zones. Now, we have to be careful. Kala Azar is not prevalent everywhere. Mostly it is available in the Bihar area and in the other tribal zones or in the other hilly areas. But malaria, filaria, dengue, these are now dengue, Japanese encephalitis. They started from the east coast of India, Odisha, and the eastern Bihar areas, but they have spread now throughout the country to right as far as Maharashtra, etc. Then dengue, malaria, filaria, these are commonly seen throughout the entire country. National Leprosy Eradication Program, a disease wherein people used to be scared and were shunned from the community and were left alone. Today they are being accepted into the National Leprosy Eradication Program with no holds barred. That means they are accepted as normal people, and minimum services actually that are available at the CHCs are for the diagnosis and treatment of the cases, complications including reactions of leprosy, along with the complications of counseling of patients on the prevention of deformity cases and uncomplicated ulcers. Now, for this I must add a word that if the deformities have come and if surgery is to be given, surgery is being done at a minimal cost for all these patients at the higher referral centers, maybe at the medical colleges or at the the state hospitals, and all facilities are given right from registration to the operation to discharge and post-discharge advice. Now, National Program for Control of Blindness is a very essential program because eyes form the main part of a human body, because without eyesight, you cannot put one step forward. Now, therefore, and this is something which has to be seen right from childhood, school health, right up to the antenatal mothers or up to men or families who are having difficulty in eating the right food. So, vision testing with vision drum, vision charts, the early detection of visual impairment and their referral. Awareness generation is very important through the IEC activities, so that if people do realize that they have difficulties in the blindness program, they would report as early as possible, and they would be examined properly at the CHC, wherein one ophthalmologist is being envisaged for every 5 lakhs population, and one ophthalmologist will cater to at least 5 CHCs. So in case this is actually, we should be having a very good referral system, wherein they do the intraocular pressure, syringing, probing. So other types of eye surgery, eye treatment, eye care is also provided apart from just the examination of the power and the giving of the lenses. Surgical services including cataract by IOL implantation is also being done and is being researched. Now, integrated disease surveillance project. Why we are accounting for all these projects is that all these programs, since they filter down from the center, from the state to the districts and finally to the CHCs, wherein they have to be implemented right down to the grassroots level. Most of the important people are based at the CHC itself. That is why this importance of learning what the CHC stands for. Now, CHC will function as a peripheral surveillance unit and collate, analyze and report information to the district surveillance unit on selected endemic prone diseases. And national program for prevention and control of deafness, very important, because these are some of the things which are actually left out. A child may not be hearing because of a previous infection, and he may not be hearing and he may not even come forward in the fact that this is important. So therefore, a regular, maybe this could be implemented through the school program so that these children could be caught at an early stage and proper diagnosis and treatment is being given to them. Most important and most difficult is a national mental health program. Now, nobody in a village, if you talk about a mental health program, sabse pehle they will say ki wo pagal hai kya, main pagal hu. And so this definition of a mental status, health status of a person is not right. Its outlook is not right. So therefore, early identification, diagnosis and treatment of common mental disorders. There should be educational activities for the prevention and removal of the stigma and early detection for mental disorders. Desirable is short-term medical officers should be trained so that they would be able to look after it. Now, the other important program is the prevention, and these are the difficult, which are the non-communicable diseases. That is prevention and control of cancer, diabetes, cardiovascular, strokes. Now, these are the diseases which are not exactly recognized very much in the rural areas, and therefore a lot of examination, a lot of information, education has to be given so that they would become used to the fact that things like cancer, diabetes, cardiovascular diseases, heart attacks can be there in the rural population also. And most important, women should be motivated for a pap smear for cancer cervix. And normally women will never come out for a pap smear or even to the center, because they feel that number one, it is not essential. Number two, how can they have cancer? So this non-recognition of these diseases by the people living in the rural areas is not exactly a very healthy approach. Then diseases like diabetes, CVDs and strokes, they are essential to know, because the focus will be on the healthy population. So what we want to do is, we actually want to modify the individual, group and community behavior through intervention, treatment, timely referral, most important, changing of a lifestyle if we recognize something wrong. So assured, now these objects have been very happily been taken over by the urban population, but as yet from a community health center, we will have to work very hard for it to be made acceptable in the rural areas. Now, investigations, higher investigations like urine, albumin, sugar, blood lipid profiles, and blood urea, creatinine, these have to be done. And so they will help in the early detection. Now, we have other programs like the National Iodine Deficiency Disorders, People have seen goiter, so people welcome this type of a program, since it also has a very simple treatment, means the presentation of iodized salt, which people would all take, and we normally associate it with the salt movement of Mahatma Gandhi. So there is an equal attachment to the country also. So very acceptable program. But in contrast, the prevention and control of fluorosis, if you tell them that teeth will go bad, teeth will fall out, nobody is going to believe it. Therefore, a lot of education, motivation has to be done at village and community level in order to prevent or to diagnose the fluorosis the fluorosis cases. So a lot of IEC activities are mostly in the form of posters, pamphlets, interpersonal communication to prevent fluorosis. National Tobacco Control Program, very important, because this is one habit which is equally prevalent in urban as well as rural areas. And what we see are, through tobacco eating, through smoking, we are going to see cancers of the throat, cancers of the mouth, cancers of the tongue, and it is desirable that we do heavy activity as far as this thing, to set up tobacco cessation clinic by training counselors for stopping tobacco intake. And most important and a very delicate program, national program for the healthcare of the elderly. This is something which normally people take it as a part of our normal life. Yeah, okay, we have old parents sitting at home, we have our grandparents sitting at home, and it is generally the lifestyle that they are given food twice a time, maybe a little bit of help is given, but no such care is being given to them and treating them as an adult or treating them as a separate case. So motivation, education, importance of elderly care, and a visit to the homes of the disabled, the bedridden persons, it must be done through the primary health center or through the sub-center. And they also hold geriatric clinics at least twice a week. And physical medicine and rehabilitation, these are primary prevention of disabilities, and this becomes mostly theoretical. So therefore, actually it depends on the ability of the CHC doctors to be able to look at the patient in a whole manner and to see what is absolutely essential, focus on their disabilities, focus on their difficulties, treat them and give necessary advice, and attach them through referral services by so many people who are visiting to the peripheral areas. And it is desirable that some treatments like exercise, heat therapy, cervical and lumbar traction, they may be given, they may be advised, and it could be done at the time. Then oral health. Dental care and dental health education services, very important, and this has to be done in collaboration, of course, with the other activities. School health, I feel, is a very important part, and as yet not much emphasis is being given, although now we must start a collaborative movement for a proper school health and screening activities in schools on a regular basis. So teachers must learn how to screen the students on a continuous basis, and they could be helped by the ANMs and the health worker males as well as the females. A doctor from the CHC or the PHC could go and visit them and advise them. So in this way, we would be screening for general health, assessment of anemia and nutritional status, visual acuity, hearing problems, dental checkup, common skin conditions, heart defects, physical disabilities, and learning disorders. Now, basic medicines to take care of the common ailments prevalent amongst young school-going children. There could be referral cards for priority services at the district and the sub-district hospitals. There has to be an immunization fixed day activity coupled with education. There could be family planning days. There could be distribution of vitamin A and IFA tablets management days. A weekly supervised distribution of all this could be done, and administration of vitamin A in the needy cases. Most important, deworming could be done through school activities, as well as through individual clinics, under 5 clinics, as and when they attend. Now, midday meals, very important to the Balwadi workers or to the Anganwadi workers. For them, cooking a meal for these children is essential, as it should be. Now we see a very nice picture, and hopefully this should become the real picture of India today. Midday meals, and what we are doing this is for health promoting schools, counseling services. We could even have yoga classes for these children, physical education, health education, and we could use peer leaders as their health educators. Now, adolescent care is a topic which is very difficult, but it has to be seen to, because we are beginning to realize that from the 10 to the 18-year-old group, where the child is shifting into adolescence, he or she is going to have their own set of problems. And as and when they start maturing, the throat breaks in the boys or the period starts in the girls, and the surface and the body starts to change its shape. So therefore, emotions will change. So therefore, they have to be seen as a complex person, and we have to see to their mental, physical, and social friendliness, to be provided preferably through adolescent-friendly clinics for packages, actually adolescent and reproductive health together. So information, counseling, services related to sexual concerns, pregnancy, contraception, these must be told to these young children. And services for tetanus immunization of adolescents is very important, because in their daily play, they are definitely going to injure themselves. So tetanus injections would be important. And for this particular group, a wholesome counseling of nutrition, referral services for safe termination of pregnancy for girls, optional and additional services as per the local need could be done, and outreach services in schools and community camps, which are desirable. Periodic health checkups should be done, and health education activities, awareness generation, co-curricular activities should be done. Then apart from this, in the functioning of the CHC, there should be a blood storage facility, diagnostic services. In addition to the lab facilities, X-ray, ECG should also be made available in the CHC, so that cases of heart problems could be dealt with. And most important, let us not forget the transport services which should be there. Now, this is a chart for the manpower of the community health centers. The existing staff is general surgeon, physician, OBG, pediatrician, and we have the nurse midwife, the dresser, and we have ambulance, pharmacist is there, lab technician, radiographer. We have, and of course, an ophthalmic assistant. So whatever are the functions of the health center, we have the necessary able trained staff in order to help with those services. Now, one A&M and one public health nurse for family welfare will be appointed under the ASHA scheme. And these are to be done. One A&M will obviously go to the sub-center. From there, she will be looking after the ASHAs. Ophthalmic assistant may also be placed wherever it does not exist. Flexibility should be there as with the state for recruitment of personnel as per requirements under the ASHA scheme, and for providing round-the-clock service at OT, labor room, casualty, male and female wards with the provision of leave reserve. And to summarize, the CHC caters to a population of anything between 80,000 to 1,20,000. 4 medical officers are appointed at the CHC. It also acts as a referral center for the primary health center and the sub-center. More advanced treatment options are available, such as cesarean sections, MTPs, blood banks, and other surgical procedures, along with the basic services available at the primary health center and sub-center. Besides, this acts as a central place for joining the hands of the primary health center services as well as its superior, the district health services. And with this, Thank you for visiting ePathshala today.